Vemuri. I'm a PhD candidate in computer and information sciences. So I would like to thank you for inviting me to this talk. Today's talk is going to be titled towards dynamic action planning and automated health coaching. So the motivation for this study is the prevention of cardiovascular disease. So the cardiovascular disease remains the leading cause of death among adults in US. So it is important that we employ prevention strategies that actually target key behaviors that are known to facilitate cardiovascular disease. So one of such strategies is increasing physical activity, which is a national priority, and also reducing sedentary behavior. But in this talk, I'm only going to focus on increasing physical activity. And at the end, I'm going to show you some of the other projects that we are doing where we actually reduce sedentary behavior too. So to address this problem, so we took the automated approach. So we provide interventions in the form of our coaching system called the B-Smart coaching system. So the idea is to provide interventions and increase MVPA in adults who are prone to CVD, meaning that they have high blood pressure or they are actually diagnosed with blood pressure. So the outline of the talk is as follows. So I'm going to introduce some terms required for this talk in the introduction. I'm going to talk about the agent architecture that we've built for the automated health coach. And then I'm going to talk about the study methods where I'm going to talk about the intervention design. And then I'm going to show you the results of a feasibility trial with 10 participants. And then I'm going to talk about a little about our future work. So introduction. So one of the paradigms that we adopted for this coaching system is human health coaching. So human health coaching has been shown to be an effective method to change physical activity behavior. So what happens in human health coaching is it's a client-oriented approach where the client sits down with the coach and then plans the goals that they want to achieve. So for instance, a goal might look something like, I want to do moderate intensity activity 3 times in a week on Mondays, Wednesdays, and Fridays. So to come up, so this might be a goal, and then the participants or the clients come up with action and coping plans. So the action plan would be, I would do exercise at 9 a.m. in the morning and on Mondays, Wednesdays, and Fridays. And coping plan would be something like if I miss out on one of those slots, I'm going to reschedule it to probably a Thursday at 10 p.m. or something like that. So here's an example of what happens in detail in a health coaching session. So the client sits down with the coach and then talks about what they want to achieve, in the sense that, as I mentioned, there is a physical activity goal that they come up with by choosing what they want to do. So, and then they talk with the health coach to discuss the strategies, barriers, and strategies to overcome these goals. So, the common barriers that we found during the study were lack of motivation or not enough time to actually exercise. And the health coach, so the client also discussed how to achieve these goals, in the sense that some could achieve them by walking, some could swim, some could bike. So there could be multiple ways that you can achieve these goals. And then the health coach also motivates them and then refers them to required resources, meaning that they provide links or documents where they actually talk about the effects of physical activity. So we try to automate most of this in our the B-Smart health coaching system. So there are some limitations of human health coaching. So notably the scalability, because there are limited number of health coaches, and each health coach can only take in a few number of clients. So there is a problem of scalability, and the other problem is the cost. So these can be, because health coaches are certified, these can be expensive sessions. So not everyone can access this. And then there is the problem of infrequent meetings. So usually health coaching sessions happen once in every 2 weeks or once in a month or so. And the other limitation is the lack of objective data. So health coaching is usually done when participants come up and say that, hey, I've achieved this. So it's mostly subjective measures. So to overcome all these limitations, so we introduced BSmart, a semi-automated coaching system. So the BSmart combines both human health coaching and automated health coaching to to increase physical activity. So it automates the goal modification and dialogue functionalities of human health coaching, which I'm going to show you in a bit what it exactly means. So in our study, the PA goals are quite specific. So in the sense that here's an example of a PA goal. So you're supposed to complete one bout of 20 continuous minutes of activity, keeping your heart rate between 100 to 115 beats per minute on at least 3 days this week. So this the target heart rate is calculated by our exercise physiologists according to the fitness levels of the individuals and the age of the individuals. So to achieve the automation, we used three devices. One is the Fitbit, and the other is the smartphone. So the smartphone, Fitbit is to collect the minute level heart rate. Smartphone is to actually hold conversations with clients, and with things, blood pressure monitor is to take the blood pressures of the participants. So here's how a BSmart intervention looks like at the end of the week. So let's assume that you have completed your goal, successfully completed all the planned bouts of in the week. So you come up, the BSmart comes up on Sundays and gives you this interaction saying that, hey, look at this pie chart, you've completed all of it. And would you like to, what you call, make your activity goal more challenging or the same as last week, something like that. So if you finish all of your goal, so you can change it to be more challenging. If you don't, then you can make it easier. So that's a quick gist of BSmart. So to implement BSmart, so we took a multi-agent approach. So you can assume agents to be autonomous softwares running on your devices or on the cloud. So as you see here, so each agent, you can assume each agent to be an individual health coach that is assisting you in your planning your physical activity goals and scheduling them. So this a distributed approach. So the agents can run on your phones, they can run on your watches. So in one of the projects, we actually run the agents on the watches. So that gives you a lot of advantages. So one of the advantages is scalability, because these are distributed autonomous pieces of software running on different devices. So you can scale almost infinitely to the number of devices we have. And the other issue is privacy, as each agent is dedicated to a particular user, so it maintains a private database that it can store the health information of the participants. So you can also think of it as final level details being stored on your devices like watch and phone, like the minute level heart rates. And then the server could take up an overall whether did you complete the activity or not, something like a more uh, less fine-grained information. So, and then there is the concept of individualization, because you have a specific agent to you assigned, so you can actually capture the context of the user and then act accordingly. And the last part is the coordination, because these are distributed. So you can assume that you want to walk with someone else. So your agents can actually schedule that activity so that your walk times can synchronize together. So we wanted to create an automated health coaching architecture for not just for BSmart, for all kinds of coaches, in the sense that, so in BSmart, we are taking a health coaching approach, but there are other studies that in which we are actually taking paradigms like just-in-time adaptive interventions. So the idea here is to actually make an architecture which can fit all these applications together. So if you see the architecture, so the context analysis is where it pulls in data from your variables and then forms a context. For example, the context could be something like your location, the weather, your heart rate, the progress towards your goal, stuff like that. And so in BSmart, you have smart goals. So you have a specific goal. So the planners and schedulers are responsible to plan these specific goals and schedule them accordingly, according to your preferences. And then there is a learner block in the architecture which actually learns from your context. So is it a good, so in one of the projects we explore, is it a good context to intervene? So in the sense that if you're at home, if you're taking a walk, that might be a time to actually intervene and say that, hey, why don't you walk longer or faster? So that's what the learner is responsible for, to learning what is the appropriate context of the user. So, and then there is the NLP generator, which actually generates dialogues with the users. For BSmart, we use finite state machines, but we are currently working on a project which we're replacing the finite state machines with natural language generators, natural language. So as I was talking, so this is intended to run different studies, not just the BSmart study. So we already are experimenting with multiple populations. So one is the cardiovascular, which is the BSmart, and we are also exploring just-in-time adaptive interventions on healthy adults. And we are working with disabilities populations with the same template architecture, systems made from the same template architecture. So the variables we use are Fitbit, Apple Watch with things, but you can literally use any variable that you want for the study. So specifically for the BSmart project, so this is the architecture. So because we have PA goals, so physical activity goals, so they're responsible to update the goals, as I showed you in one of the images in the previous slides. So you have the participants have the option to update their goals. The planner is responsible to form up new goals for the upcoming week. The scheduler is responsible to send messages at specific preferred timings of the users. So there are multiple messages that the BSmart sends. Specifically, there are three types. The one is on Monday mornings, we send out saying that, hey, this is the goal that you should achieve. And in the midpoint, we show the progress of how much did the participant achieve, and then come up with a few messages saying that, are you on track? If you're not on track, so we send out some of the information like links to which physical activity might, I mean, like the positive effects of physical activity. So, and then there is a context analyzer. Context analyzer takes in the Fitbit data and the Withings blood pressure data. So methods. So the vSmart is there are multiple components to the vSmart system. So one is the health coaching. So as I mentioned, it's a semi-autonomous system. So health coaching is done by both by humans and by the vSmart automated system. And then there is the weekly SMS feedback. So in the feedback, you say what is your goal reminder. In the midweek, the goal progresses, and in the end of the week, you say what is your goal summary, and then you have the choice of selecting next week's goals. So the messages that the BSmart sends are the underlying theory is the self-determination theory. So we actually take PA states of change for each of the users. Either they are in action, contemplation, uh, and stuff like that, and then we actually customize the messages accordingly. So we also take whether the participant is a blunter or a shunter, so in the sense that how receptive are they to actually getting positive news versus negative, threatening negative news when they actually look at the messages. That's a form of motivating users to increase their physical activity. So the BSmart acceptability study results for 6 weeks in total. So the first week is the baseline week where we give actographs for participants and then ask them to wear actographs for the first 1 week. And after the first week, so the participants sit with the human health coach and then form the specific goals and come up with strategies and barriers to overcoming these goals. So from week one and week two, BSmart gives automated interventions 3 times a week. And at the week two, there's a midpoint call with the human health coach where they come up and discuss if they want to change their goals completely, or in the sense that they want to change their strategy. And there is 2 more weeks of BSmart interventions, and at the end of the week four, so there is a post assessment. Again, the participants wear their actographs. So the idea here is, so we want to calculate the total MVPA in week and at the post week and see if there is a difference between the both. As this is an acceptability trial, we did not find much difference between MVPA, but we're going to report other results. So, and this is the plan for the 3-month randomized control trial. So we'll be split into 2 groups, the control group and the intervention group. So the control group is only with Fitbit, they get no interventions, and the BSmart condition gets the. So we're currently running the randomized. So here's what a BSmart conversation looks like. Onto the leftmost corner, here is the start of the week messages, where the BSmart summarizes what is the week to stay on track to meet the goal. So try listening to an audiobook or a podcast while you walk, something like that. So these are customized based on underlying uh, physical parameters that we took from the participants. And the midweek messages look something like this. So on Thursdays, BSmart sends this messages saying that, hey, this is what you have achieved this week. And if you're not on track, so it gives you an open-ended question like, in what ways could you be more active to improve your quality of life? So, and then the user responds, and then we take those responses and then analyze them later. So this is the end of the week conversation. So at the end of the week, so BSmart again sends you a pie chart saying that whether you have achieved the goal or not. And then if this is the case where the participant has achieved their goal, So now you have options of increasing your goal to be more challenging, or you can make it the same as the last week. So if you choose something like more challenging, you can make it either longer or harder. So a 20-minute bout, a longer would be something like transitioning to 22 minutes instead of 20 minutes, or harder would be something like your target heart rate is going to increase. So for example, here 102 to 116 is going to increase from 115, something like that. So the eligibility criteria for this study was participants had to be midlife, meaning that they had to be 35 to 64 years old. They had to be diagnosed with pre-hypertensive and stage 1 hypertensive or stage 1 hypertensive, and they had to be physically inactive with less than 100 minutes of MVPM. So we employed multiple recruiting methods. One, what being some of them being the UD Office of Employee Health, and then we put in posters, flyers, and posters at multiple places, and there was also mode of word of mouth and also clinical referrals. So there was a moderate risk, a moderate CVD risk. So every participant had to get a medical clearance from their physical physician. So here are the results of the acceptability trial on 10 participants. So this is the overall post-survey results of what is the satisfaction of BSMART. So the satisfaction overall was good, in the sense that we had a rating of 3.6 out of 5. Participants specifically liked how they had the choice of choosing goals for the upcoming weeks. So the goal progression suggestions had a rating of 4.2. So, and then to evaluate the BSMART system, what we did was we saw how many of the planned bouts that the participants achieve. So to explain this better, so let's assume that a weekly goal is 20 minutes of three bouts of 20 minutes each, and then across 4 weeks, this is going to be 4 times 3. This is 12 bouts of 20 minutes, assuming that the participants did not change their goal. So we saw out of the 12 bouts, how many bouts did they successfully complete. So a successful completion of bouts is you have to maintain your target heart rate continuously in the target heart rate range for 80% of the time. So meaning if it's a 20-minute of planned bout, so you have to at least maintain 16 minutes in your target heart rate. So if we take the average across participants, we got 41.8% as success, overall average of the successful bouts, which is not that great, to be honest. So we wanted to explore what was happening. So why was there a low percentage of accomplishment? So to do that, so what we did, the first table reflects. So we relaxed the notion of bouts. So if your goal was, again, I'm going to repeat the same example. So 3 bouts of 20 minutes each in a week. What we did, we relaxed the notion of bouts and only looked at how up to 60 minutes in the example. So how many minutes did they spend in the target heart rate without maintaining their heart rate consecutively? So when we pull that image, so if you maintain your target heart rate for 50 minutes, irrespective of the bouts, so you're going to be something close to 90%. So this is the percentage that they've maintained in their target heart rate, a majority. So this the percentage jumped up from 41.8 to around 82%. So there was a huge difference. So meaning that there was something happening, in the sense that people were maintaining their target heart rate in the target heart rate ranges, but the bouts, but they weren't accomplishing that full bouts. So to further analyze, what we did was we redefined what. So we had a new notion of bout called a partial bout. So for example, in your same example, if a bout was of length 20 minutes, what we did was we looked at if they maintained consecutively their heart rate in the target heart rate range for at least 10 minutes, which we considered it as a partial bout. So we considered that a successful partial bout. So if you see the numbers here, so the parentheses represents the successfully achieved full bouts. So if you see for a participant like 106 or 107, so they had a lot of partial bouts, and meaning that the 20 minutes was decomposed into multiple 10 minutes. And we don't know the reasons why they did not actually do a full 20-minute bouts, but what we know is they have a lot of partial bouts and they were attempting to actually finish their goals. So to quantify this difference, what we did was of the executed plan. So divergence is a very common planning metric. So a divergence or a plan difference of an initial is the planned, and that they come up with the health course, meaning like 3 bouts of 20 minutes each in a week, and the executed plans, which could have multiple partial bouts. So we wanted to see the difference between these two. So the divergence is close to 6, meaning that you come up and sit with a health coach, and then when you're actually 6 actions from the plan, from the initial plan, is quite a lot. When you do that, so there is literature and physical activity supporting that if you have a very specific initial, if you have a very specific plan, so that will help you to achieve goals. But if you divert significantly, this loses the validity of having a very specific action plans. So that raises a question of should the automated systems dynamically adapt their action plans according to users' fulfillment of their goals. So to explain this, so let's assume that this is the initial plan, the same example, 20 minutes 3 times a week. So, and then let's assume that the participant only partially fulfill their goal, like 10 minutes on Monday mornings. So one recommendation for the restructuring of the action plan would be reschedule 10 minutes to Monday at 9 p.m. and then keeping the rest of the actions as the same. Or the second recommendation could be splitting up the 20-minute goals on Wednesday to 15 and 15 minutes, adding this 10 minutes, making it 30, and then you're splitting up to 15 minutes on Wednesday morning and then night. So the question is, if you actually action plans and give them to users, would they be more effective in fulfilling their goals? So that's an open question, but we did some analysis in the sense that to build such systems, to build such a recommendation system, the planning systems need preferences. Um, so the context is different in the sense that in the recommendation 1, so you're walking at night at home, and in the recommendation 2, you're splitting up the goal from 15 from that 10 minutes, you're adding up to the next part, and then you're splitting it in 15 minutes and 15 minutes. So this all depends on the preferences of the user. So for automated planning systems and scheduling systems to actually accommodate this, so they need to take preferences. So what we did was we analyzed the transcripts from health coaching and then came up with a bunch of preferences that should be added to automated planning systems. So here's some of them. So one at the bottom level is the preference values of the actions itself. So you might want to what do you call walk, have a higher preference over walking versus biking or running. And then you might want to split up your goal into 2 bouts rather than having a one single bout. And then this accumulates to give these most preferred recommendations. So we are currently working on that. So I'm currently building scheduling algorithms which can actually provide these recommendations. So some of the other work that we did was just-in-time adaptive interventions. So instead of health coaching, we take a different paradigm called JITI. So just-in-time adaptive interventions idea is that why don't we actually catch you while you're walking and then give you an intervention and tell you to walk longer or faster. So that's what is happening here. So we used Apple Watches for this. And then we detected if people were walking once they were walking. So we took in these parameters where what was the location of the walk. So are there any calendar events, for example? So if you're parking at your parking lot and walking to the office, there is no point of giving an intervention saying that, hey, why don't you walk longer? So we took that contextual data and then we took the information of previous walks. So if I know that you're walking, like for example, at every day from your home at 5 p.m. and then coming back at 5:30 to your home after doing a 30-minute walk, so that might be a good time to intervene. So we actually look and learn if that is a good a context to intervene at. And then the other parameter is the weather. So it helps in saying that, hey, it looks sunny outside, why don't you take a walk? So something like that. So this is currently under human subject trials. We are piloting it with 20 participants, and we already have like 12. So we are waiting for the rest of the 8 and so that's it from my end. Thank you so much for inviting me. I can take